be protective of the teachers. That's so good. So finally, the faculty responsibility, as I said, I'm not going to look into all of this preparation, planning, structuring, and even for a small one patient encounter. Otherwise, you are losing a learning opportunity for your students. I'm going to stop here. So I'm just going to ask you, what is that one thing that you learned out of this session? I know all of you are almost dozing off and going to sleep. So what is that one thing you learned out of this session? And what is that one thing you would like to do differently because of understanding these principles? Please write it down on a piece of paper and hand it over to me. I will use it later. I'm not going to ask, read it out. Please write it 30 seconds and I'm going to hand over to Savannah.
It becomes second nature that we will be able to do it regularly. Okay, so now when we are engaging the students in such a planned session, what are the different tools which we can use? That is what we are going to discuss. The traditional ones we usually do is we give them a case. So that is what I have been exposed to. I think most of us have been exposed to that. We are given a case and we are asked to go through the history examination and then finally present to the teacher whatever history and examination findings are, discuss the differentials and then the management as well. When the other students, and there we involve the other students as well in the discussion. So that is the usual methodology. Is there any other method you employ? Anybody else? Any other methodology which you are used to? No, that is fine. In the clinical rounds, what is the usual methodology which we use? No, that is one thing. Is we assign a patient to a student, and then the student or a group of students examine the patient, take history, and then present to us. That is the traditional methodology. Is there any other method which you employ? In the rounds, you show one sign. Particularly that will be useful in a learner doctor method. When you are doing a grand rounds in a learner doctor method, we usually go around important signs or symptoms which somebody having, we just show them. Okay, that is another way. Any other methodology? So we are probably, we are short of methodology. So that is where we need some existing tools which have been tested and it has been proven to be effective than the traditional methodology. So we are going to look at some of these tools which we can use in our students. Okay, so the first one is called as the 1 minute preceptor. I think everybody would have, some of you would have heard this thing called as 1 minute preceptor. Preceptor means the teacher. Whoever is teaching is called as a preceptor, where the teacher is going to be available only for 1 minute. Okay, the teacher is going to be available for only 1 minute. So that too in a very specific case. Yes, sir. It goes nearly 10 minutes, but a teacher's involvement is needed only for a minute. So it is for the student, it is a 10-minute process, but for the teacher, it is going to be a 1 minute process. No need. That's not needed. So here, this is not like the mini CX where it has to be conducted in front of the teacher. This is usually happens in a busy OP rounds. No, we are in the outpatient. We are getting a patient. We can assign a student, go examine this patient and come and tell him. Okay, he will go, take the patient inside, take the history, examine the patient, comes back to us. And after that, probably that 1 minute may not be exactly 1 minute. It might go on to 1 minute or 2 minutes, but the whole process takes around 10 to 15 minutes because the student the student goes inside with the patient, he is going to spend some time with the patient. Okay, so that's the process which the student does. But what are we going to do? That is the 5 micro skills which we are going to do. Once the student comes back, this we can employ even in a inpatient. As we are, when we are taking the student along with us, as ma'am has said, we have today, we have selected 4 or 5 patients, and there are 5 students. So you can just allot each of them and then ask them to examine the patient, and then you go on rounds with each one of them. Okay, you can employ an OMP even in an inpatient setting. So how do you do it? So you have given the patient, assigned the patient to the student, and at the end of the encounter with the patient, the student comes back to the preceptor who is a teacher. So the first thing we ask is, get the commitment. Get the commitment. What do you think it is? So imagine I have given a patient, a student, a swelling in the neck. Okay, so the student comes back and I'm asking him, what do you think the diagnosis is? The student says it's a thyroid swelling. Okay, so that is what. So first, get a commitment. A student has to commit. What is the diagnosis or whatever the finding is, the student has to commit. The second thing is probe for supporting evidence. Okay, so you ask the student, why do you say it is thyroid? The student will say, it is moving. So how do you say thyroid is thyroid? How do you say thyroid is a thyroid? A neck swelling, when do you say it's thyroid? Yes? Because you were in the other discussion, I just wanted to bring you here. When do you say neck swelling is a thyroid? Louder. Louder. Is it a difficult question? Okay, so when it when it moves up with deglutition, when you swallow it moves up, that's the second thing, probe for supporting evidence, and the student says, because it moves up with deglutition, I call it a thyroid swelling. The next thing is, teach a general rule. That is, whenever a swelling moves up on deglutition, it is most probably a thyroid swelling. Okay, so that is the general rule. So this is basically, they experience something and the experience is converted into a concrete fact. Okay, and whenever they see a subsequent patient with a swelling in the thyroid which moves up with deglutition, they know it's a thyroid. I am giving a very simple example to actually drive home the point that what this particular OMP means. Okay, so next thing is reinforce positives. Reinforce positives, yes. You identify, you ask the patient to swallow and you look at the swelling and you identify it is moving up with deglutition. So you reinforce the positive and correct errors. Possibly this patient would have had a thyroglossal cyst and not a thyroid swelling, which is also a neck swelling, but would have forgotten to look for movement on protrusion of tongue. So this would have been a thyroglossal. What they did is right. He had a swelling in the neck, which moved up with deglutition. So everything what I have done is right, but only that they forgot even a thyroglossal cyst can move up with deglutition. Only that you have to do a protrusion of tongue to find out it is not a thyroid swelling, it is a thyroglossal cyst. So you correct it. So that is the next step, and also you plan for improvement. Now you go and read about thyroglossal cyst. It's a very, very simple thing. So whenever you want to teach something very specific to a student, and you have an opportunity to teach it, you have a patient available in the ward where this particular point can be taught to a group of students, you can employ what is called as the OMP method. It's a very, very simple thing. Whatever, everything the student has to do, you just have to spend a minute or two with the student to drive home this particular point. I hope you are following what this OMP is. So it is basically get a commitment, probe for supporting evidence, teach a general rule, reinforce positives, and correct errors or plan for improvement. Okay, so this has been followed in over 500 institutes worldwide, and it has got a 75% more improved retention, and the encounter is actually limited to 1 to 3 minutes, and there's an 80% teacher satisfaction in this methodology. So this is evidence of how OMP is successful all over the world, and we also can try to implement it wherever it is possible. It is a very, very simple thing. In our busy schedule, it is much easier to actually do it. Only thing is, as ma'am said, always map it. Nothing mapped to the competency is not going to yield us any result. Okay, so that once you start mapping it, we know exactly, as ma'am said, in your subject, you know what are the competencies which has to be taught to the student. So in the third year, I have shown all these things. In the clinical competencies, I have covered all these things in the third year. And in the fourth year, these are the things which are not yet covered. So I need to cover it later. So it is different from a theoretical class where you can define, today I am going to teach this particular, because you don't need a patient. But when it comes to a clinical setting, you might not have a patient. You cannot plan something. That is, the students are going to come in third year, I am going to show all these cases, which is not possible. Whatever the case is available at the time, you need to get it. Otherwise, what you can do is, whenever you are getting a very interesting case, make it into a case book. Create a case log. Take some photographs of the patient. Take some videos of the patient. Keep it ready. Okay, you can use that as well as a teaching material for the student. That way, you have, even if you don't have the patients, because that is going to be the future where you might not get patients to be shown live to students. Instead, whenever you're getting an interesting patient, always keep their records. Keep some videos, keep some photographs of these patients, so that can be used as a teaching material for our students. I hope we are you're all with me. Everybody looks dazed, even after a tea. No, good, right. So let's go to the next one, which is the SNAPS model. Okay, so we have completed what is called the OMB model, which is a very short model, which is for a very specific learning object, very specific learning object. But a SNAPS model is very similar to a long case, or whatever case we are providing to a student. It is very similar to it. Okay, only that it is more structured. So whenever we give a student, we are not telling them anything. But here, we exactly tell them what they are supposed to do. So first S is summarize the history and findings. Once they come back, you give a patient to a student or group of students. When they come back, they have to give a summary of the history and the examination. The next thing is narrow the differentials. Once they summarize the history and the examination findings, they have to give some differentials, from 2 or 3 differentials, which we do it regularly. I think this is not something which is new. The Westerners are very good in giving names for all the existing methodologies. So once we look at our best practices, we can also come up with our own clinical methodologies to teach our students. Next is analyze the differential. So the student has given 2 or 3 differentials. He has to tell why this thing, why that thing. We are all used to it. But only the next thing is a little different. Probe the preceptor. So probing the preceptor. Preceptor, I told you what preceptor is, the teacher. The student is given a chance to probe the teacher, which we never do it in a normal long case or a short case examination. Here, after the student has analyzed it, he will have some doubts going in his mind. So here is an opportunity for the students to question the teacher. I am having all these doubts in my mind. So I am going to clear all my doubts. So we give an opportunity. That is the only thing which is different from a normal long case record to a SNAPS model. So we give an opportunity for the student to clear his doubts. Okay, not our doubts, no, the student's doubts. And then finally plan a management and go on to select some case-related issues for self-directed learning, or otherwise we call it as a homework. We give them a homework, or now it is fancily called as the self-directed learning. Okay, where you select a particular case, you discuss something, there will be definitely some unanswered questions will be there. The students have to take it back and then do a self-directed learning and then come back and discuss the next. I hope you understand this SNAPS model. Only difference is that the first P is probing the preceptor. Again, there are evidences to say that this is better than a traditional case taking. We have sent some material. Anybody went through those materials? Some of these. Whatever I have discussed, The OMP is the 5 micro skills teaching methodology, which I've sent you the article. Please go through it. The snaps has also been sent, and this is called as the workplace based assessment. So those are the teaching methodologies, and we are going to look at some of the assessment methodologies, which are also basically, we are looking at formative assessment these days. Correct? So whatever we are assessing is assessment for learning, and it's not of learning. Okay, so we can use this workplace-based assessments for teaching the students. So there are many workplace-based assessment methodologies. The first one is called as a mini CEX. So whenever there's a clinical encounter, a doctor is there, a patient is there, and a student is there. Whenever we are going for a rounds, the students are coming along with us. The doctor will be there and the patient. The doctor will interact with the patient and the students will observe. This is the earliest level of clinical teaching. They learn by observation. The interaction between a teacher or a doctor and a patient. Because in the rounds, as we go, we will be interacting with the patient and the students will be there in the rounds, they will be observing. That's a basic level of clinical learning. The next level is you involve the student also in the discussion. The second level is involve the student. As we are seeing, you ask the student to examine the patient as well, or ask some history, and then discuss there and then. So there's a 3-level discussion happening between the patient, the teacher, and the student. That's the second level of clinical teaching. The third level is called as the hot seating. The hot seating is one where the teacher just is an observer. The teacher is an observer and everything happens between the patient and the student. You don't do anything, you just observe. And that is something which we never do. That is something which we never do, and that is where we can learn a lot about our students, what mistake they make in the manner they take history, what mistakes they make when they're examining. All these things are found out in what is called as a hot seating, but it cannot be done always. Okay, so that methodology is called as the mini clinical evaluation exercise. Okay, I'll just go through what this mini clinical evaluation exercise is. So, but that is what is called as a mini clinical evaluation. I hope you are there with me about what a mini clinical evaluation is. Next one is DOPS. I think some of you will be doing it. Okay, whenever it involves any skill, the student is allowed to perform the skill in front of the teacher, and the teacher observes whether the student is doing those steps properly. Like, if it's undergrad students, you can ask them to wear the gloves. So when they see whether they are wearing gloves properly, whether they are washing their hands properly. There are many important skills which a student has to learn, which can be observed in person and it can be written. So that is called as a direct observation of procedural skills, all the more useful for postgraduate students. Next is case-based discussion, which we just discussed, where you can take real cases and keep it as a material for discussion of cases. So that's called as a case-based discussion. You can select the best cases where you have an umpteen amount of teaching opportunity. Take such cases, keep them in the department itself. You can keep system-wise. You can keep the interesting cases, respiratory system, cardiovascular. You can just keep all these interesting cases, and you can just draw one. Today I am going to teach a cardiovascular. I don't find a patient. You just go draw one of these patients. It will be something interesting to discuss with the students. So that is called as case-based discussion. And we have 360-degree evaluation, which is a little more complex and might be the ideal method to assess any student. But we are not going to discuss that here now. Okay, let's go into one by one, which is the first one is a mini clinical evaluation exercise. So what do you do here? So you basically, if you are looking at it, you look at the history taking skills, the physical examination skills, communication skills, clinical judgment, professionalism, organizing, overall clinical care. All of this we can assess when we are with the student. And if you can see here, I'll go to the next one. Next slide. So these are actually, if you go to Western countries, the students in a year, they have to perform 10 to 12 mini CX, and they have to fill the form and keep it there, what is called as a portfolio. I think you know what a portfolio is. Portfolio is whatever a student has accomplished in his 3 years or 5 years, he keep everything as a record. It's called as a portfolio. In his portfolio, every year he should have completed 10 to 12 mini CX, which means it is not, the onus is not on the teachers, the onus is on the student. If the student has not completed the 12 mini CX, he cannot progress on to the second year. Now what we are doing, all the onus is on us. Just transfer the onus on to the students. Tell them you have to complete these many things. You should have completed your, that is where your logbooks become very important. Your logbooks, 4 cases, if you have not completed in the first year, you cannot go to the second year. Make it mandatory for appearing for your exams. Something like that. And if you do that, then the onus falls on the students. But then it will be a self-directed one. Now they are hating it because we are actually forcing everything on them. Instead, you tell them, this is your end point. We don't know how you actually go through it. It's flexible pathway. Whatever pathway you want to take, which we are showing only the end point, and we are not telling which is the path to be taken. Okay, so that one such thing is called as the mini CEX, where they have to do 10 to 12 mini CX, and it can be on different systems, and it has to be on different systems. They cannot have one system and complete all the mini CX. This is called as a mini clinical evaluation exercises. Please go through it. It's an excellently written chapter on workplace-based assessment, and please go through that particular article. And next is the DOPS. So DOPS doesn't know. Demonstrate appropriate preparation, appropriate analgesia, technical ability, aseptic technique, seeks help where appropriate, post-procedure management, communication skills, etc. If you can look at it, the technical skills is only one of the 11 points. But most of the time, we give importance only to that one point. But there are many other things which are involved in a procedure apart from just the technical skills. So technical skills is something which we teach them in a skills lab. Whenever we go, how to catheterize is something which is done on a mannequin, where we give them a checklist and see whether they are going through every step correctly. But when it comes to a real patient, there are so many other things apart from the simple skill level, where right from indication to final post-procedure advice, a student has to be completely thorough in any particular skill. I think, these are the various benefits: enhanced learning, contextual relevance, and I told you, right? So the challenges in doing a mini CX is it requires dedicated faculty time. Unlike a OMP where you just have to spend a minute, here you might have to spend 15 to 20 minutes or sometimes more than that with the student to complete a mini CX. That's why you cannot have mini CX exercises a lot. Okay, it's ideal for a postgraduate, but for an undergraduate, when you have 3 or 4 students posted with you in a clinical posting, at least once you can conduct a mini CX, and start doing it, your students will become much better. Okay, so I think we have come to the end of the various tools which can be utilized in your clinical teaching. So over to you, ma'am. So it's 4:30. We'll try to 4:24.
Thank you, Saravanan, for briefing all this instant methods. It was more of like we wanted to recap what was supposed to be done. But the only difference again I'm telling is the action. We know it. We practice it. The whole workshop is about to have your own reset. What I know I want to practice. That is also the conversion we have to do in the group of those students to make them practice the module. So just going on, now we are going to have the actual practice workshops. And there are 2 worksheets that are given to you. Okay. So the template, there are two templates. One is for the worksheet for planning a clinical system. Okay? The other one, after you have planned, I want you to go into groups of 4 and also have some students along with you. You have to plan a clinical round. You can use standardized patients. You can one of you act as patients. Use a scenario where a standardized patient can, because there are no real patients. You can use mannequins if you want to demonstrate any skills. And you decide on one clinical encounter in a ward round. Actually, it's going to be a demonstration of 4 patients. Ideally, you have to select from a list. So when you are actually planning here, one should play the role of giving a list of cases, then they decide on which case, then you have to write a plan for how you are going to conduct the round. You can even decide how the standardized patient or a skill or something is demoed there. Then take these students for a round. So once you are planned and you are going to execute it, group A, group B, group B, C and D. There are 4 patients which is going to go for a clinical round. So when the A is doing the actual clinical round with a 1 patient, the rest of you will be observing and marking on the observer checklist of what went well and what could be done better. Okay, you don't need to fill all forms. For group B ward round, each of you, the groups discuss and fill 1 form. Is it correct? Have you understood? First, the group is assigned. 1 person presents a list of case. The group selects 1 case. You put a plan for that, including how you are going to actually plan the round, because there are no real patients. Then you actually conduct the rounds with the students. When group A is conducting the rounds, the other 3 groups will discuss and fill 1 form, observer form. Once you have finished your role, the next B group will present and you become an observer. Like that we finish all the 4. Once you are done with all the 4, the groups that have presented already will also fill the observer form as a self-assessment form. Is it still confusing? Is it confusing? Yes, you can. Yes.
So, initially we all will be divided into 4 groups.
Yes.
Okay. In these 4 groups, each one of us are going to take up a case, like after event.
So, from a list of cases,
From a list of the cases, we are going to pick up 1 case. For example, group A is going to demonstrate it, like the bedside teaching or the rounds, and group B, C, and D will be evaluating it, and one of them will be filling the observer check.
Yes.
From each group.
Yes.
So one person from B, C, and D will be filling.
Not 1 person. It will be the group reflection should be filled by.
Yeah. Okay. The same thing will be repeated with the other groups.
But then the group which has finished it also should do a self-evaluation in that observer. Same observer. It's also called as a self-evaluation. There is an observer. The students will not know. They will not be part of the platform.
There are 3 bits.
3 bits of me.
The students will come later. Yeah, now your planning has to be done. No, maybe more later. Once a day.
something, then you play what to do, what not to do. Instead of that, we are supposed to give you some notice. And tell you this is what prepared or thoughtful, discuss, have your questions. You are not supposed to know everything. That's why you are saying it's not a crime not to know. It's not a crime. So now, basically, 4 steps. First is to talk to the patient. Special pulse is 1.13. So in general examination, without specific examination.
This today or yesterday, we informed them earlier that come study or with some questions prepare to talk to and examine a heart failure patient, read something about it, come with questions coming here. Now here we have got Dr. Krishna playing the role of the patient here. So when the students now come here, they are a little sensitized and we are a little oriented. Not about the entire thorough cardiac case presentation, but specifically about, as is mentioned in the booklet with the norms, about IM. That is, we wanted the students to play the role of presenting, not just examining, not just observing, but presenting. So they do something and they also present to someone the findings. And then the pre-reading checklist was, in this case, in our scenario, to read on the related condition, maybe on the phone or otherwise, and prepare key questions for discussion.
What
related
materials?
On net or book it might have. Their questions should be answered, explored. And expected learning outcomes in connection with the IMV, that 1.10, 1.11, 1.13 are they should be able to elicit history and do some establish rapport, able to do general examination, specific examination, peripheral pulses, and specifically measure BP in an accurate way. But why it is selected, why we selected heart failure, why they are studying, because it's common, relevant, everybody will be expected to know something, talk will be there. That's the reason why we selected heart failure. It could have, in your case, maybe something else that has come to the ward.
Just to clarify, huddle is a briefing to everybody on their roles before you start the role. The part of what you are telling, what they have to learn is in the preparation of the point. So that's the huddle means I have done all the planning. I have to inform this team what role they will play. That is the main role.
In the huddle on the faculty side, if you see, Prabodh, sir, he was providing the resource for us to check after this is happened. So that's about we'll do the segment afterwards.
Yes.
So
I think the students are coming now. You can, yes, you're the teachers.
And students. Hello students. Okay. You must be relaxed. We are next. So here is somebody who has come and is in the hospital, and as we discussed earlier coming to, as you are given, so depending on, have you read anything about, have you remembered anything about it? Yesterday we said anything about, what topic is given here? Heart failure. Have you ever heard of anyone in friends, relatives, family, friends in hospital having a heart failure? No. You are not. Any other? Is it a common, relatively serious, or very rare? It's pretty much common. So many other members may ask you doubt, whether in the hospital or at home, or somebody may ask you, can you suggest something or help something? So now to know.
Yes. Now, when we put up our hand, we'll just bring some comments. So this introduction, since he's doing it for the first time.
So
because that might make the patient happy.
These are our college students, and they'll be inquiring a little bit more about the things, and it will help in refining the treatment for you, because some of those questions will be much more detailed and they'll be helpful. At any time you feel uncomfortable or any difficulty, okay, just raise the hand.
So when I
and we
say
are
2
going-
weeks, that is an excellent one what you did. At any time you are not comfortable, you please let me know. It's an empathetic way of, teaching. We are bringing empathy when we are using students to teach.
And after the question everything is over, I will see, we will see, I will see, our team will see what they have extracted, what information they got. And again I will come back to you. You tell me if you felt any sensitive, delicate, you tell me after the interaction is over. Okay? Fine. Good performance and get going. Students, okay, the stage is yours. You do, they will get yes.
ఏ కంప్లైంట్ ఎప్పుడు వచ్చారు మిమ్మల్ని కొన్ని ప్రశ్నలు అడుగుతాము, మీకు ఏమైనా ఇబ్బందిగా ఉంటే అది మాకు చెప్పండి. ఇలా అడుగుతాం, మీకేమి ఇబ్బంది లేదు కదా? ఎప్పటి నుంచి ఉంది ఆయాసం?
2 వారాలు.
ఇంతకుముందు ఇప్పుడు ఇలా ఏమైనా జరిగింది? అంటే ఏమైనా పని చేసినప్పుడు ఆయాసం వచ్చిందా, లేకపోతే ఉన్నట్టు నడుస్తుంటేనే వస్తుంది? ఇంకా బరువులు ఎత్తినప్పుడు కానీ ఏమైనా పరిగెత్తినప్పుడు నడుస్తున్నప్పుడు
బరువులు ఎత్తినప్పుడు ఆయాసం.
ఇప్పుడు నడుస్తున్నప్పుడు ఆయాసం వస్తుంది, కూర్చున్నప్పుడు తగ్గుతుందా లేకపోతే తగ్గట్లేదు? దగ్గు కానీ ఇంకేమైనా ఉన్నాయా?
Okay, so the history can go long. So there is whatever they have done to establish rapport, that point is observed. Now 1.11 is about general examination and systems examination.
I would like to interrupt. So this is what practically also will occur. When you have too many objectives, then you will be spending too much time in that one patient. So that is why your learning objective has to be very specific. Instead of having 4, you can have 1.
So here it was given 3. So
No, that's what. See, now practically when you see, because history taking itself will take a long time. So you can have only history taking, so that you use your time specifically. That's all.
okay. So the next 3 objectives you have to connect: general examination, peripheral pulses, BP.
Sir, I have a doubt.
Yes. No problem. Don't worry. Okay.
Love the sound effects. Love the.
He's asked to do something and he doesn't know. That is it. So you ask the question, shall I demonstrate? When they are struggling to do that, can I help? And you demonstrate. He is not knowing it. Then you have to teach him.
If you find something is
Okay. Do you want another demonstration?
See, that you don't do. You will be putting down
So,
the patient.
peripheral pulses.
As well, he doesn't know. Should never do
Upper limb,
that. That's a
lower
good
limb.
question.
Sir,
There's a
yes.
learning here. My comment here.
So what?
One question she asked is if the student doesn't know, I said everybody has got the right to know and right not to know. So that not knowing when they have accepted, you only have to fill it by teaching and not try to see, even subtly if you do that, you're not doing it with intention, they will feel as though I don't know. So what you should do, I will demonstrate. Or ask a postgraduate, please come postgraduate, why don't you demonstrate to all the students at this? So that is
So centers are for the limbs. Central pulses are carotid cylinders. So all peripheral, whether they are present or not, and details can be later on. So brachial, radial. So we can give the information. Pulses 1 and good. Nigita vachudam ela. Okay. Then you can check the popliteal pulse by making the patient prone or supine also. Practice more and more. So pulses. The popliteal fossa, diamond fossa area. And requisite. If any pulse is missing, you will note. If there is edema and everything, they are auxiliary findings. But pulses, if they are all there,
Yes.
cold, clammy,
Like what I want is, he not introducing many of the objectives into a single one?
that's more, I would say I am clarifying, but let him see.
I felt, because he was struggling to find the radial pulse. So I think, a little more demonstration, where to actually look for it. Because, again, we were a little, because
Actually, madam, one of the objective is examination of peripheral
Peripheral pulses is the point.
That is-
And one of the
Right
competence.
from starting, what I felt was, introduce the student to a single objective line by line. How will you assess that at a stretch if you are including too many specific learning
No, you
objectives?
can still do it. If this is a final year student.
Yeah.
The level, I'm just telling you. See, again, I'm using this opportunity to tell you. Multiple objectives rapidly running as a reinforcement that they have already introduced to the concept is not wrong.
With respect to this case,
This
non-failure
is
case,
it's
there
not
are
wrong. You got my
18
point.
bedside teachers, 8 competence.
It all depends on the level of the student. Now you may have a final year and the sixth semester student together. What will you do then? You have to give them grading. That is called as what is called teaching high and also addressing the low. Go high. When you are doing around with a postgraduate, undergrad, first 6th semester, 8th semester. So this is a little complex part of it. Since you questioned, I am answering.
Yeah.
my only thing was, we
In all of
can
this,
reinforce the technique of doing.
So
Correct.
they are in final year right now. So upper limb, lower limb, they are present or not? But most commonly, even the public will be interested if you are holding their wrist or not. So both for the rapport, confidence, and for your ability.
Okay, so this discussion, while it's happening here, if it is involving something not there, edema is there, all this should happen outside the patient. Whatever discussion, not in front of the patient. See, the whole idea of this wardrobe thing is thinking that there is a patient who is looking at you, listening and involved. And there, but it is afraid that I don't know. These two are the basis of an empathetic teaching and learning. That's what we are concerned, bedside teaching, we have to go into that. So when this discussion is happening, say please come. Now that we have demonstrated, come let's go and discuss. You pull them out to a different and then go and discuss. Here he is worried, one pulse is not there, now you know my pulse is not there, he start counting to go.
So,
No, sir, this is, you are doing a great job, sir. In fact, you are subjecting yourself to a very good analysis. You are extremely well. This is an extremely, learning opportunity. Please give a big hand.
of all
And we
the,
are taking liberty in interrupting.
sure, that enhances whole interaction value. And of all the peripheral pulses, general public, movies, otherwise, they all expect you to hold their wrist. And then that itself will be reassuring, developing confidence, rapport. Any other examination you do, they will be much more confident. So, radial pulse, you might have tried with few members. So, many methods, many detailed methods of evaluation with one finger, with two fingers, with three fingers. You can check the vessel condition, vessel wall suppleness, and the degree of pressure, and the rapidity, pulse, rhythm, regularity. So much is there. నాడు పట్టుకొని చెప్పేస్తారు అంటే డాక్టర్ అంటే చాలా వాల్యూ. సో పీపుల్ లైక్ someone, the doctor who holds their wrist. So even if you know the condition, perhaps you would want to wish. Effect of the silence. You can hold on that. Any difficulty, let me know. Any crashes, let me know. So you can try with two fingers, not three. We can practice that later on. So press gently. Okay. Then keep pressing up. That's it. Okay. Then, like guitar, do you know guitar? No. So keep the distal finger just lightly, and the proximal finger, that middle finger. Only with the middle finger you press on the artery. The pulse becomes. Do you feel the pulse stronger or weak? And do you feel when you keep pressing very hard, do you feel the index finger to have the pulse again? Yes. And if you press the middle finger even harder, you will stop the pulse. You will feel. So, depending on the gradient of pressure you are applying, you can also check for the number of patients. You can check the BP also. How much is it? Depends on the skill. It's there. Is it there or not? So good. Good pulses. Similarly,
Please give a big
strong pulses.
What is your
Tatvagna.
Tattva. Okay. Now, Tattva forgot all people around and he became engrossed in what he was telling. Did you all notice that?
Exactly.
He was so excited. He was telling the fingers that he could feel it and I could see that. Is it not? Did you forget? If so many people are looking at you, you were only looking at the pulse and you were feeling it. That excitement came out of it. If you have seen review your video, you will know that. So that is the immersion that we have done.
video review
That's because when he is teaching you, actually your learning is what is seen as an expression there. So that is the kind of immersion we have to give it to the student, that you are with the patient, you are doing this, you are learning.
Nobody? Okay, fine. We'll have a little discussion. Not everything we talk will be about you. Okay. I'll come back. I'll come back again. Okay. Thank you.
Please give a big hand. Fantastic, sir.
I hope now
When reduced litigation, there is evidence. So we have already done that. It's more than 12 minutes that you have spent. Actually, if you look at the patient also became engrossed in the because you reassured him, I'm not talking about you, I'm only teaching them, so he is also listening. Okay, so if you explain to the patient, see, we did OSCE for the exam. When 40 students examined and did the OSCE, but the patient did not complain. He became like our king Madri one look, because they are all coming to me, no, I only have to give the history. So if you tell them that this is in advance, they are prepared. So that is the little extra thing that we have to do.
anybody did the observation checklist? Yeah. So
You can, none of you can do, like,
So
what
they
you do.
themselves have done it.
They
No,
themselves.
one of their team members have done a self-evaluation.
Good, no problem. You can make your team.
From our
Yes.
side,
Yes.
2 lines. From us, a round of applause from us and all of us to the medicos Tatvagna and the 2 others who stood by, who had the same really kind of thing. So, fantastic. So much confidence giving to your patients and attendants, and you have personal satisfaction. Touch is considered the must primordial of all human emotions. Doctor touch will be very reassuring. Pulse is నాడి చూడడం అనేది so much on the image. All the technology వచ్చినా సరే, don't forget the value of, you might know the condition even without holding the pulse, but you holding the pulse and taking the pulse will make a big difference. So 2 finger, 3 finger techniques and everything did well. Round of applause for the initiative. Standing by. He also doesn't know what to do, he's going to do kind of thing, so he stood by, he didn't run away. And from Dr. Krishna, he was apprehensive little we could see, but he over time he grew confident that we are not having any injections, any blood sample collection. So that was not there. So applause to our actor. Thank you, ma'am.
She's suffering pain for the past 2 years. Her main complaint is the difficulty in starting. Now and then she's got some stickiness in the throat. So she's afraid of, is it going to become complicated? That's why she came. That's the brief history. So we were supposed to examine, demonstrate correct method of examining the thyroid case, and I will give the reports and you have to correctly interpret it. That's all. The common questions examiners usually ask: why you are thinking it is thyroid? Why thyroid moves from the patient? What are the other swelling that moves from the patient? What swelling starts with difficulty in swelling condition? These are the few questions examiners repeatedly ask. On the examination, which part you concentrate upon? Reading material, you have to read Das, little brothers, and Bailey, little text, short text. Reading. Next,
Yesterday in the WhatsApp group, we have added some reading material. Okay, reading material on thyroid. Have you prepared it? Yes. How to prepare it? Yes. Preparation. Okay. Say yes. Okay. You have prepared. You have gone through all the material, right? You have gone through all the multiple choice which has been given to you.
history and
For want of time, you want to do one thing because complete exam, history exam.
Morning for Japan, sir. Good evening,
you ask her what is the class? There are how many methods of calculation of debt? No problem. There is a flexibility and introduce you. Use your own hands. Ask the patient to flex the neck. And ask the patient to swallow. When the patient is swallowing, you are able to feel the gland is moving under your fingers. And you have to interpret. So, what is the shape of the shape of the semen? Even if you can palpation also can show the shape, that's the and how is the surface, how is the borders, everything. And even you can see the consistency, mobility also. All these things are supposed to be in the classical method. Majority of the finding is in classical method. If necessary, if I will come to the front and do other techniques as well as this is one. So here I am seeing the surface, extent of the swelling, and also how is even I am feeling the consistency, and also I am seeing pulses. I am supposed to calculate the character. So this is which character, common characteristic I am supposed to calculate. Both characters simultaneously should not calculate. So from first one character, lower part of the swelling is vulnerable. These are the very difficult things. Suppose if the both lobes are enlarged, then I will go to the front of the patient and do a special technique called the IDS technique, where I will push this lobe and catch with the hand and ask the patient to start. Please start. Like that. This lobe also will calculate. So by these two techniques, 99% of all findings of thyroid are entire. If patient is short neck, then we will do the other method, Bizelow's method. Bizelow's method, we will ask the patient, share the patient please, and try to extend. You try to extend, so you are able to see the swelling properly. You can appreciate it. Ask the patient to swell. So these in examination, these are the three techniques. If short neck, will be Bizelow's. Otherwise, for every patient, classical method, and if both lobes are involved, lobe characteristics can be appreciated better in the history. So these are the things. And the very sign that's called palpation of the common characteristic. Majority of the people, common mistake is palpation. Become something like you should do any pulse, you are supposed to palpate 3 fingers. 3 fingers were. So please, as I told, now try to. difficulty in swallowing or stickiness in the throat. If such complaint is there, what should be there in your mind? Because yesterday I asked her to read the material. In that material, what? So if such type of history is there, what to suspect? The Hashimoto's diabetes, which is more common. Hashimoto's diabetes.
That's this. So we will complete it, sir. We can take the discussion. We have to take it away. Otherwise, they will start thinking about.
But now we are in a situation where patient will not agree for an exam. That could also, here she is agree. But that may also happen. He may allow the consultant to do that, the professor to do that, but she will not do. So what do you do too many times to avoid that? I have posted this video. Look at that. Come and stand beside him as survey and then ask him. So that it's not allowed. Because that patient is, I'm giving a situation where patient is refusing or not allowed. So, yes. Yes. Excellent.
Now our objective is to assess the students regarding history taking and the technique of inhaler usage. That is the objective. Take proper history and
So let's stick to one thing.
inhaler usage.
So the student should be able to demonstrate.
Assess and demonstrate. Assess and demonstrate.
Find the gap and demonstrate the
Find the gap.
How they are using the
नमस्कार నా పేరు ధరణి నేను ఎంబీబీఎస్
child may not be able to answer all the questions. You can ask her caretaker.
అమ్మాయికి దగ్గును ఆయాసం నెలలో 2-3 సార్లు వస్తుంటుంది హాస్పిటల్కి వస్తుంటారు ఇచ్చారు ఎక్కువ
Your voice is very clear.
అందరూ రెగ్యులర్గా వాడుతున్నారు
అంటే వాడుతుంటాం కానీ అది మమ్మీ మా మాట ఎప్పుడు ఇచ్చారు ఫోటో వాడమన్నారు ఇచ్చాము సరిగ్గా
ఒకసారి ఎలా వాడుతున్నారు చెప్పాలి
అది అప్పుడు టీవీ చూస్తున్నప్పుడు అది ముందు పెట్టి పడతాం లేదా అది ముందు కూర్చున్నప్పుడు ఫోటో పెట్టి అట్లా కూర్చున్నాం 2 సార్లు మాకు 2 ఇచ్చారు ఒకటేమో ముందు రంగు ఒకటేమో పింక్ రంగులో ఇచ్చారు అదోసారి ఇదోసారి
మీరు ఇన్హేలర్ వాడుతున్న విధానం కరెక్ట్గా లేదండి ఇప్పుడు చేసి కరెక్ట్గా ఎలా వాడాలో చేసి
చెప్పండి ఈసారి జాగ్రత్త వాడతాం లేదా బడి కూడా పోవాలి
Imagine this as a inhaler. You just show it. Demonstrate it. You first demonstrate it and let the child do after your demonstration. You first demonstrate it. You first demonstrate on yourself with the help of the dummy and then ask the child to do. Or you both can demonstrate the same to the child so that she can do independently without depending on the father from him or after. Keep it close to the mouth. That's it.
మొత్తం అవ్వాలంటే ఒక నోట్లో కాదు
The way you are telling is good, but it's not 10 seconds. For minimum 30 to 40 seconds. Only single actuation, not multiple actuation. Single actuation of the device should be coordinated with inspection. The child to demonstrate so that she understood what you said. No. She will demonstrate on herself, imagining it as an very good. You have demonstrated very correctly so that the child understood what needs to be done independently on her own. She has done that. So what was the extra reading material which we were supposed to read on this topic? Based on that, what difficult to read task? Why was it difficult to read in this child? Why is she coming? Any other comorbid conditions which we need to take care of?
Again, yeah, exactly. So this is where, we get carried away.
ప్రశ్న అడుగుతారు పరీక్ష చేస్తారు ఎవరిని చెప్పండి ఇబ్బంది ఉంటే కనుక నాకు చెప్పండి సో తర్వాత నేను మాట్లాడతాను తర్వాత పట్టిక మాట్లాడతాను ఇద్దరు అట్టే నిల్చోండి we have discussed yesterday regarding the case and already briefed them and you examine for formation of the reports and check for errors. This is it.
పరీక్ష చేస్తాము
Okay.
We want the patient volunteer to manifest tenderness, produce more tension in the enhance the accelerate the learning. We are just carry. We are just only like this.
No tender history, palpation of liver cell, and no increase in the continuum.
Actually, in the case of liver disease, who is in recovery phase, usually these liver and head are disappear. So now you will be credit
Sir. Parలేదు.
ER respiratory distress or interpreting any intercostal retractions or in the examination of the areas, how to examine. This is where the problem, am I right? This is where their problem is. So what we do when they are doing the case examination, when they present the history, we are not seeing. So somebody even from the patient also can present. The others are all only getting involved only when the presentation is happening. And when we do the physical examination, most of the time they are not confident in that. So when you demonstrate only the abnormal finding, they have never learned what is the normal examination. So this is not, it's not only with you, with every one of us. Because we presume that they know. And even if we presume and they know also, this is not happening only in your institution. Throughout India, our medical teachers are really struggling to be lifelong learners for benefiting you and your learning, so you will take care of us. That is our so we want you to be the best kind of doctors, that is why we are doing all of this. So take that into your heart. Use this particular incident as a motivation for you to prove to your teachers how best you can be in your
Dr. Margaret Shanti ma'am to give away certificates to Dr. LathaRavichandran ma'am.
Wait.
And now I invite ma'am.
One more round. Ma'am.
I request rounds of applause, please. Dr. LathaRavichandranDay1Part ma'am. Dr. Srilakshmi ma'am. I request Dr. LathaRavichandran ma'am to give away the certificate to Dr. Margaret Shanti ma'am. We invite everyone for the
workshop, madam. We have learned so much, the importance of these skills, how to teach them, and there was a lot of zeal to do that, but you showed us the right path, how it has to be done in the right way. Thank you so much, and thank you so much for Manaswini, and the importance of it, where we are facing a lot of trouble and the shortage of clinical material also. That was a big trouble in many of the colleges. And because of these things with the simulated patients and with the standardized patients, that will become much easier for us, and will be helping a lot of students also to get used with the skills. Thank you so much. Thank you, madam.
Actually, I came to this workshop with a lot of hope, and I'm facing a lot of difficulty especially in clinical rounds, and where the limit is the third semester students will be there, and ninth semester will be there, and seventh semester will be there. There are differences. Now I understood that I have to plan ahead like that of my own teacher who used to do it like this. So that's the first lesson I'm going to implement it from Monday onwards. That's the point you have specified when we are struggling to do that, and we have to break down all the skills and specify the things. So that's another carry home message, and I'll try to implement that one also. And really thankful. I got a lot of things in my mind, and I got a lot of what I should do. Of course, I have sometimes I feel like that we are too much explaining the things which are not required. Maybe may not be, but I will try to work on it. Thank you.
only one who will make people kneel on.
సాయి సార్ వచ్చి నేను తీసుకున్నాను.
Madam, please. Smile. Thank you.